Delighted to host this podcast, one of a series of many related to the dynamics we're facing in healthcare today. I'm Dr. Britt Berrett. I'm the director for the Center for Healthcare Leadership and Management. Today we have a topic of conversation as it relates to the pandemic hitting our country and our world, and it relates to the financial side of this. Now, as I've shared in the past, this is such a dynamic and broad conversation. So we're trying to focus in on the specifics of the business side of healthcare. The Center for Healthcare Leadership and Management hosts a podcast. So if you're ever curious about the business side of healthcare, I'd invite you to look up that podcast. We talk about all different aspects of the business side of healthcare. Today, hosting and leading this conversation is Professor Dan Karnuta, who has a tremendous history in the business world and has joined the faculty here at the University of Texas at Dallas at the Jindal School of Management. I'll turn it over to Dan in a moment, but I'd like to introduce two other esteemed colleagues, Dr. Don Taylor, who is on faculty here at the University of Texas at Dallas, and Dr. Keith Thurgood, who also is on faculty. Dr. Thurgood is the director of the graduate program and has a lot of professional experience as well. So, getting to the meat of the matter, I'm going to ask Professor Karnuta to introduce himself and give a little bit of his history, his background, as we spin up on this conversation today. So, Dan, tell us your background and welcome to the webinar.
Thank you, Britt. Well, my background is a bit long in the tooth, but I'll be as brief as I can. I am a CPA. And I spent most of my career in some form or other in the finance area, most of it in the finance area around healthcare. Most recently, I was CFO of a company called Conifer Health Solutions, which is a hospital revenue cycle management outsourcing company, for about 7 years. Before that, I worked for Perot Systems for about 18 years, and I was the CFO of their healthcare operations there. And then prior to that with Pricewaterhouse. So I've been around.
You certainly have. You joined the faculty. You've been teaching healthcare finance and the economics of healthcare. And I will say your student evaluations are absolutely superior. We're just grateful for your expertise and your real life experience that brings the business side of healthcare into the classroom, and we bridge that gap. Well, we have had some interesting dynamics and challenges, Dan. Let's talk a little bit about the financing and what's going on in the most recent stimulus package. But give us some of your thoughts as an overview as it relates to the business side and the financing and accounting of healthcare in their current status and current situation.
Okay, this could go on all day, but we'll try to break it down into chunks here. And first, I'd like to say that to the students that are out there, this COVID-19 crisis that we're going through, and it truly is a crisis and probably feels like a crisis to you, and it should. But this is just another one of those things. I've gotten a lot of looks from you guys as I've taught you over the semesters when I keep bringing up things like Enron and the .com bust. These things happened 20 years ago. To me, it's like they happened yesterday. But you guys are like, of course we don't remember it. We were 3 years old when that happened, or we were 4 years old when that happened. And I'll bring up 9/11, or I'll bring up the Great Recession, which is just 2008. Okay, now we're just talking about 12 years ago. And still, that's not really fresh in your minds, but this one's yours. Okay, COVID ID is a big one. It's a very unique one. None of us have gone through any of this either. None of us old guys have gone through this either. This is yours. You're going to be talking to your kids about this, and they're going to be looking at you like you look at us now when we talk about .com bust or Enron. So take what you can from this and learn from it, and use it as part of the history you draw from when you confront the unknown challenges of the future. Because this is the big one, and we're all going to get through it and learn from it. But to Britt's question, so there's a whole lot of data points out there that we can look at. First of all, the estimates at the very low end are that about 2.5 million people in the US could require COVID-19 hospitalization. And if you look at that, okay, 2.4 million people out of how many people, the 300 billion or whatever we got, it's not,
300 million.
what's the 300 million, sorry, what's the big deal? Well, 2.4 million requiring hospitalization, there's only 925,000 inpatient beds available in the US, and less than 100,000 of those are for the critically ill. And then if you bump that up against Northern Italy, which is one of the first hotspots outside of China that turned up, Northern Italy hospitals are above capacity right now, and they have a higher bed per capita than the US. So this is why all the preparation's going on. I mean, we're seeing this in the US, and hospitals and legislatures and governments, they're getting ready for it. And I mean, that's a good sign. You're seeing the flattening of the curve graph thrown around all the time. And so, I mean, that's something to at least feel good about. We're not just sitting here and going to let it happen to us. So what are hospitals doing to prepare for the patient inflow that could be and probably is coming? Well, they're postponing elective surgeries to reserve beds for critical COVID-19 patients. And the current estimates I've been seeing are that over 70% of elective surgeries have been canceled. And we'll get to the financial implications of that in a second. But they're also expanding capacity, meaning adding more beds, and that's aided by relaxed government regulations on the number of beds that they can actually have in any given location. So it's not like they could just go start adding beds in the basement or rooms that, or the waiting rooms. The government first had to relax the regulations around that, so that you can imagine the regulations around healthcare. So the government, one of their first actions was to go look at all that stuff and say, okay, what do we have to do to make sure that hospitals don't have their hands tied and they can actually do some of these things?
Yeah.
Telehealth is another thing, again, aided by relaxed regulations and Medicare reimbursement rules. Medicare wasn't big on reimbursing for telehealth. It was just too easy to get scammed. But they've relaxed those rules so that telehealth now can become a real player in this pandemic. Temporary hospital beds are popping up, but of course that's limited. That's limited by the number of staffing, clinical staff availability. So you see things like convention centers, dormitories, ships. You saw the ship probably in every paper in America had that on the front cover.
Two ships.
Gigantic ships coming in with Red Cross ships with beds on them. So, that's the photo op of the day are these beds popping up everywhere. But again, there's limited. You can have as many beds as you want if you don't have the doctors and clinicians to treat the patients. The beds don't do much good. They're repurposing existing healthcare facilities into hospitals. So things like rehab centers. Well, those aren't hospitals, but they're kind of close. So those are the type of things that are being converted first into hospital type settings. And then of course, to treat all these patients, they're bringing retired clinicians out of retirement. So you've got doctors and nurses who thought they were retired and happily so, now being brought, and most of them quite happily so, back into service to help out. So you've got, this preparation for the influx of patients is happening. And what's that doing to the hospital's financial side of the hospitals? Well, these elective procedures that are creating the capacity for COVID-19 patients, that's the big margin business. So hospitals are basically cutting off their high profitability elective type, non-emergent procedures. And I've talked to my classes about acuity and how many students know what acuity means, and nobody raises their hand. Acuity just means how hard is this thing to treat, right? And the higher the acuity, the more you're going to get, the doctors or the hospitals are going to get paid for it, typically. So, they're cutting off these high acuity type of procedures that they rely upon, the hospitals, to make their profit. And right now, a lot of the hospitals are sitting there with empty beds because they can't treat those patients because they're waiting for the inflow of patients to come in. Another thing is the increased cost of supplies we've been hearing about. Forget about the cost, just trying to get a ventilator or a mask, these days is hard enough, but the cost is going up too. I mean, it's still a supply and demand type of environment. So these masks that used to cost 30 cents a piece, I've seen them as high as $7 now And the hospitals have no choice. They've got to pay for it. The shortage of clinicians is coupled by an increase in labor price. If there's a shortage of clinicians and hospitals need to increase their nursing staff, they go to a contracting nursing staff company to add some more nurses. Guess what? The price is a lot higher than it was 2 months ago for this type of labor. A lot of hospitals for this preparedness for this surge are overstaffing. They're overstaffed right now. They're ready to get ready. And of course, overstaffing is, a CFO's nightmare. That's what CFOs of hospitals spend a lot of their time doing, is trying to dial the staffing to be exactly, what they need. Well, right now they're dialing it up to be prepared for an influx that hasn't hit yet, but they're waiting for it.
Dan, let me jump in here, and I'm going to invite the attendees. If you have a question, there's a chat function on the side, so you can address it to everyone or address it to me or to Dan, probably me, and I'll raise the issue. But Dan, yes, serious issues, but how bad is it? I mean, are we going to anticipate serious economic hardship for hospitals as their expenses go up, their revenue is reduced, and there's no pandemic hit at this point? Are we going to see some serious economic hardship in the healthcare space into the future? What's your guess?
Well, it's not are we going to see it? We're already seeing it. I mean, it's an absolute going to happen. And you think of the hospital industry and how it's capitalized. A lot of the big hospital systems, even the smaller ones, are capitalized with debt. Okay, they're highly leveraged. It costs a lot of money to put a wing on a hospital, right? It costs a lot of money to open up a few site surgery centers. Hospitals don't have that kind of money laying around, so what do? They take out debt. If you look at some of the big hospital companies, Tenet, HCA, I mean, the debt burden is significant, and that's appreciated and understood by Wall Street and the players within the hospital system. But in a time like this, okay, that's turned on their head, because the monthly principal and interest payments don't just stop. So they're already coming in. So those April, we just flipped to April. So those costs are coming in, and the cash flow is not there to pay for it.
It's kind of like if you have a mortgage payment or you have a rent payment, and you're going to get your payment from your company, but all of a sudden that check goes away. You've still got to pay your rent. You've still got to pay your mortgage. And eventually they're going to kick you out of the apartment or the house because you can't pay. And some of us are seriously concerned about rural facilities and critical access hospitals that are living on a very, very thin margin. Very thin.
That's exactly right. Exactly right. And what do? If you need more money? Well, you try to get another loan. Well, who's loaning to a hospital right now? All right, it's not the best risk profile. So basically, the money supply has dried up for hospitals. So and I've talked about lines of credit. That's part of the classes I teach, and so my students know what I'm talking about. Most of these hospital systems have revolving line of credits that allow them to basically go to a bank and draw down a certain amount of money, and the bank has to lend it to them. And hospitals don't like to tap those funds. They're just for emergencies. And guess what? The LOCs, the lines of credit, they're the ones that are tapped. So they're tapped, and now the next stage is, okay, now what? So hospitals were just laying in wait for this CARES Act to be passed to at least give a little bit of relief, to what basically the barrel of the gun they're looking at with. It's all about cash flow.
Hey, Dan.
Yeah.
Thanks for that insight. And this may piggyback on some of the chat questions, but in our classes, in some of the intro classes, we've been talking about the CARES Act and the stimulus package that was passed by Congress last week, and the roughly $100 billion that's going to hospitals, and the upcharge or the increase in revenue for Medicare for those hospitals that are treating COVID-19 patients. Do you think that's going to be meaningful at the end of the day?
Well, yeah, I mean, absolutely. It's $100 billion is meaningful. And in fact, $100 billion is about what, the hospital association's lobbyists wanted. So they basically got what they were lobbying for, 3 or 4 weeks ago. outside of, they also wanted more government loan availability. They didn't get that in this particular act, but they got most of what other stuff they asked for. Of course, that's what they thought they needed 4 weeks ago. So what they need now is probably more than that. So, if I can get into that just real quickly, what we don't realize, when we look at this thing, is that there's really been 3 phases already of relief that have taken place. A few weeks ago, there was the Coronavirus Preparedness and Response Supplemental Appropriations Act. And this was, again, several weeks ago, which gave $8.3 billion of emergency aid package to help contain and treat the coronavirus-caused respiratory illnesses. So the CDC, state Medicaid, state unemployment, got some of that $8.3 billion. Now, when we're talking about $2 trillion, which the CARES Act was, that seems like a little drop in the bucket, which it kind of is. But that happened several weeks ago, phase 1. Phase 2 was $100 billion that came in a few weeks ago. The Family's First Coronavirus Response Act, it was called. And that was, legislation guaranteeing free coronavirus testing, providing paid emergency leave for employees. And it enhanced the unemployment insurance that people got, not to the effect that CARES does, but it increased that. So it started, now we've got $108 billion that have been added as of a few weeks ago. And then CARES is phase 3. And then CARES is the big bullet, right? It's $2 trillion. That's with the T. And let's put that, before we start digging into, what's in the CARES package, let's, first of all, put it in perspective. So just over $2 trillion for the COVID-19 pandemic impact. Now, from when China reported the first death until that $2 trillion package was passed, 11 weeks passed. 11 weeks. Put that in perspective, which don't have to look back too far. 2007, 2008, the Great Recession caused by the subprime mortgage crisis. It took Congress 80 weeks to get the first significant bill passed, which was $787 billion. Okay, so not quite 1 trillion. So 11 weeks it took Congress this time. It took them 80 weeks, during the last crisis. And that 80 weeks brought the total funding up to about 2 trillion for that crisis as well. So this one package, 11 weeks, equals the entire relief that took 80 weeks to pass for the last big crisis. Likewise, and a couple more data points, it took about as long in the subprime crisis of 2007, 2008 for the Fed to slowly reduce the cost of borrowing, so interest rates to reduce. So over that 80-week period, rates dropped, to near zero, 2-3%. However, the Fed acted very quickly this time, and we're already there. We're already almost at zero cost of borrowing. So the Fed, right off the bat, pulled the trigger on this one. They were able to pull the playbook off the shelf from the 2008 crisis and get right on it. And one more data point I'll give you just for fun here is in the depths of the Great Recession, the weekly initial unemployment claims were barely over 500,000 people. That means filing unemployment for the first time. For the week of March 21st, 2020, so a couple weeks ago, 3.3 million claims were filed. So the Great Recession was kind of like a drip, drip, drip impact on the economy. 500,000 jobless claims a week for an extended period of time. And this time around, 3.3 million hit in just 1 week. So, that's the backdrop. This was, it can't be understated the monumental achievement this was for Congress to actually, Congress and the Senate and the House to actually get this thing passed. Now with that, if you pass a piece of legislation that meaty and that big and that all encompassing, and we'll talk about in a minute how many people it impacts and businesses, it's passed quickly, but there's a lot of holes in it. Meaning, how do you get your money?
Do you think it's enough?
It's not enough.
Wow.
And in fact,
wow.
And I'm not being really risky going out on a limb saying that because they're already preparing phase 4. Okay, so this package was the CARES Act was phase 3. Phase 4 is already starting to work its way through the houses of Congress right now.
So for the $2 trillion bucks, let's not talk about the pork, meaning that's a term that's used when you have legislation. You just throw extraneous things in there that have nothing to do with the current crisis. Let's set that aside. That'll be taken care of in November, right? Let's talk about what the care package will do. Do physicians get some type of help? Do hospitals get some type of help? Who's getting help on this?
Yeah, and I mean it's really, like I said, it's a monumental piece of legislation if you think about how our Congress works. But I mean, just listen to this, and if you go to pick a website and whoever you like to read regarding what's in the bill, you'll get the numbers kind of categorized a little bit differently by everybody that's out there. I've never seen it. I've looked at 4, 5, 6 sites, and it's kind of different in each one you look at. But in a nutshell, about 30% of the $2 trillion is going to go to individuals and families, 25% to big business, 19% to small business, 17% to state and local governments, and then about 9% to public services. And that's where healthcare is, by the way.
Wait. How much of that $2 trillion goes to help hospitals?
That's in the public service piece, the 9%. So let me get to the actual numbers now. That's just to set the stage.
Wow.
Individuals and families are getting most of it. The 30% share, not most, but the biggest share. And like I said, then big business and small business and state governments. But healthcare, let's get into what we're here to talk about. Like I said, healthcare did okay. They got $100 billion for hospitals. And that's for COVID-19 response and lost revenue from these elective surgeries. The increase by 20% of the Medicare payments for treatments. Basically, my class, goes through this. You calculate based on the codes and what's happening to a patient, and then those codes turn into a price that the hospital gets to bill Medicare, and Medicare reimburses. Well, add 20% to that. One of the things the bill did, and Keith just mentioned that, you get an uplift on that. There's also, now that's estimated not to be enough though. You look at some estimates that are out there the last couple of days. Hospitals are set to lose $1,200 to $8,000 per COVID-19 patient, even with this stimulus. But the other the $100 billion basically goes to offset the cost of, like I said, lost revenue, temporary structure, the cost of temporary structures, the cost of leasing new property to put the structures in, the cost of medical supplies and equipment, the cost of the extra workforce, the cost of retrofitting facilities to turn them into hospital beds. Basically, surge capacity is a big piece of that $100 billion. Now that's part of what hospitals get. Now, the problem with that is that it's, what the bill says, it's the Secretary of HHS. It has to administer this and explain how hospitals apply for it. Yeah. And that's a whole nother, ball of wax right there as to how it's going to happen, how they're going to pay. I mean, the secretary's under extreme pressure because I think he's got like 60 days to report back to Congress of how it's going. So, my sense is that it's going to be a relatively streamlined way of getting money to those that claim they need it. And then once the pandemic is over, 2-3 years from now, there's going to be just a swath of auditing coming out of the government to audit who's taken what money, did they really deserve it, sort of thing. And the bad players are going to find themselves behind bars, pretty quick.
Is that just to hospitals, or does that expand into physician practices as well, small mom and pops, or?
Well, I mean, it's really just for hospitals. Now, we'll talk in a second about where the practices get covered is under the small business relief. So they get some as well. So there's 100 billion there, around 100, round 100 billion. There's 20 billion additionally for veterans healthcare in the bill. 16 billion for strategic supply stockpile. So basically the government's, saying that, okay, this isn't going to happen again. Let's put some money in there and build up our supplies again.
Right.
16 billion for SNAP, which is the Supplemental Nutrition Assistance Program. 11 billion for drug access, and then a few billion for this, that, and the other thing. So that's the 170 billion for public health, of which 100 billion is strictly for the hospital side of things.
Do you think the hospitals are we going to see hospital closures? That to me is a fundamental question.
And that's a really good question too. It'd be interesting what Don and Keith think about that. But back in the day, and I would say this is probably 10 or 15 years ago, coming from the revenue cycle side of things and the finance side of things, our position was always, when our receivables balances from patients we started to see it rise in some of our rural type hospitals or critical access hospitals out there on a limb. Our mantra was always, well, hospitals don't go bankrupt.
Yeah.
All right. So the state or the feds are going to come in and save it, and typically they didn't, back in the day. But the day's not here. In the last 15 years, it's been okay. Hospitals just like anybody else, any other business, and they've been going bankrupt. And they've been let, and it's been let happen. So that can happen. Now, it's hard to imagine, and I'm just imagining now, that in this particular crisis, the federal and state governments are going to let that happen. Okay, you can see how fast they moved to get this $2 trillion package passed. I just can't see critical rural type hospitals, especially in this environment, just let hang out there and go bankrupt. Because if that were the case, it'll happen soon. Because
let's check in with Keith and Don. Keith, your thoughts on that? First, you have to unmute your phone.
Yeah, let me unmute the phone here. I think there's a couple of things to think about. You brought up, I think, Brett, the idea of the rural hospitals. And in Texas, it's a particularly acute problem. So we have roughly a large percentage of the hospitals in Texas are in rural, 300 plus. And if you think about what has happened in Texas over the last decade or so, we've actually closed about 120 or so rural hospitals in Texas. So I think it's a real concern when you think about access, the quality of care, underserved areas, and those kinds of things that we're going to have to pay really close attention to.
Good. Don, do you want to jump on the Keith wagon here, or what are your thoughts?
Sure. Just a couple of comments. First, it's immediacy to this. And I think the financial situation is let's respond to the current need. I just saw today that CMS just approved 85 new codes for telemedicine related to COVID-19, which is never going to go away, by the way. That's one of the things I would like to say in all of this urgency to respond. It's sort of like when I talk about health benefits, I've never seen a health benefit we didn't keep forever. Yeah. So, as we reach milestones or we create what I heroic hurdles to cross in the system for hospitals to survive, I think those will be retained. They may not be in the magnitude or the extent, but a lot of these relaxed natures are going to be retained. However, I applaud the back end of this with the audit side and the increased need for transparency over time. Because I believe there is a sort of a blessing embedded in this on understanding your costs probably better than you ever have. And it's going to take some diligence. However, unfortunately, those folks are being furloughed that would be looking into that while the clinical folks are being given overtime. So there's some adjustments in the near term that are happening. But I believe long term, this could reset the system to function better, more, first of all, in an integrated fashion with collaboration on efficiencies, but also in a better knowledge of cost and how those are born.
But let's jump in. Do you think the hospitals are going to be closing in the short term?
I think some could be, but I don't believe they will during this financial crisis, particularly in hotspots. And that's where—
Agreed. Agreed.
I think hotspots are going to be protected. I'm interested to see how hospitals integrate with common settings. Like, for instance, I just was off on the phone an hour ago with a group setting up the McCormick Center in Chicago, in cooperation with the Corps of Engineers and the federal system, with contractors spinning up to help it. Well, now, how is that expense going to be incorporated into the staff expenses for the health systems throughout Chicago? And how's that being done in New York as well?
Okay, good. Dan, back to you.
Another thing in the bill, right on point, or the act, right on point to this is, there's been an expansion of the Medicare advanced payment program for hospitals. And what that is, just in a nutshell, is instead of having to actually bill for a Medicare patient, send it to CMS, and then wait for CMS to pay that bill, hospitals can apply to just get an advanced lump sum payment, and based on history, and apply for it, and then Medicare will just basically give them a big lump of money and say, here it is. You've got, essentially, and what the act did is it extended the amount of time that they have to then pay that back. So they've got to pay that money back, but the whole process is that as they continue to these hospitals continue to bill Medicare and get payments from Medicare, then they have the cash flow to actually pay that back. So it's just an advanced funding. So that will hopefully stop some of these hospitals from getting into this cash flow minutia that we've been talking about.
But a big entity can do that. Another question was, what about outpatient facilities and freestanding outpatient facilities? They're probably at greater risk because they don't have the economic capacity to float money for a period of time. So I think that those in physicians' offices are at real risk for closure or consolidation.
Yeah, well, and if you look at that, there is a relief in there, small business relief in the package, $377 billion for small businesses. And small businesses would be, your dental practices, your physician practices, your under 500 employee type practices.
It'll be interesting to see how quick they can get the money, though.
Well, and that's the whole problem. So I've actually talked to a couple of practitioners in that area, and that's their main concern. The ones I've talked to said, listen, our practice, we can survive for a couple months if we furlough our people. We'll continue to pay their health benefits. And what this act does is it basically allows them to take out a loan, a forgivable loan, meaning they never have to pay it back as long as they meet the terms. And it's based on, I think it's like 2.5 times their average monthly salary expense, rent expense, debt management expense, that type of thing. So it essentially is the government saying, listen, we understand you have to furlough these folks. The government's basically going to pay for it. But you got it right, Britt. Is it what's keeping them up at night is not that the relief is going to be there. It's how fast can the money get to them. And again, the act doesn't go far enough in detail, and the act doesn't have a couple forms attached to the back that says, okay, rip these forms off, fill it in, and we'll give you the money. Right? They're still making those process rules right now.
Small practices are saying, hey, I'm going to cover my employees. I love my employees. I have 5 employees. I love them. I'll pay their salaries during this. Well, first week, that's fine. Second week, that's fine. Third, fourth, fifth, sixth week, all of a sudden you can't maintain that. Dr. Thurgood, you were going to make a comment there?
Well, I was going to preface this by saying there's no such thing as free shipping with Amazon. I know that most students don't want to hear that. There's no such thing as free shipping. So back to the finance piece, there's no free shipping with Amazon. There's no such thing as free healthcare. So of the CARES Act, the $100 billion that is going to the public sector, the hospitals, the $20 billion or so to the veterans, and the strategic supplies is another 15 or 20 billion, as Dan mentioned. Dan, what's your point of view on how will this be paid for? At some point, we will either pay for it in taxes or premiums or deductibles or something. I don't know. What's your thought on that?
That's a great question. I love this one because it's actually not that difficult, because you hit it just by spitting out the things you just said. All right, there's only a few ways to do it. Right there, the government, first of all, is in the unique position, unlike you and I and other businesses, that they've got printing presses and they print money.
Well,
Right?
Dr. Barrett does that. That's how he can afford his lake house.
So So here's the 2 trillion. Let's just, we got the printing presses, just keep them working overtime and things will be fine. So you're either going to have to, like you said, raise taxes or pay through it by taxes. You're going to, first of all, you're going to increase the federal debt, right? That's what happens immediately. And then you got, but what people don't like to talk about, because certainly not with family members, because then you get into political discussions, is what are you going to cut? Okay, what is Congress going to cut that's going on right now that we as taxpayers are paying for? It's all coming out of taxpayer money. I mean, that's the only way that the government gets money, is through us or through investments on our money that we give them. So it's taxes, but things can also be cut. Programs can be cut to pay for this as well, but Congress doesn't like to do that. Depending on what side of the aisle you're on, you can argue either side of that.
We could be on this for hours. Let's pivot if we can. I want to get to a restaurant and go see a movie, maybe go see a show as quick as I can. I'm tired of being sequestered here in my home. What do you think is going to happen to the economy when the social distancing requirements are relaxed? What's your sense of what the economy will do?
Mine is fireball startup.
I agree.
But unfortunately, I don't think it's going to be like, okay, let's say it's mid-May and the starting gate for the economy has been set at June 8th, and then the gate opens and everybody runs. It's just not going to happen like that. I mean, we can use the test cases that we have, which is just China. I mean, they were ready to go and now they've pulled back, because it's not until there's a cure, an easy vaccine for this thing, and it just becomes another common cold virus. I can't imagine it's going to be a shotgun start. If it was, then I think things would fire back up, pretty quickly. But I think it's going to, just personally, I think it's going to be more kind of a sputter start.
Let's kick to Don and Keith. I'm sorry?
It'll go. Once it goes, though, it'll go.
Let's kick to Don and Keith on their assumptions on what the future will look like. What can we anticipate? Don?
I think that I think that it will be spring loaded. And I think that if I think of the supply chain right now, for example, so there's hoarding going on with things like toilet paper and water and hand sanitizers. The manufacturers that I've talked to, they are all gearing up in big ways. So for example, they are producing things that we need right now and converting some of their manufacturing lines to the commodities that we need right now. So I actually think that in 2 weeks or so, I think the supply chain will start to normalize. And I think that by the time the gates are lifted, I think the supply chain will be well positioned to meet up the pent up demand.
That's interesting. Don, what do you think? What's your take?
Well, I also believe the supply chain's gearing up, but I also know it's kind of relying on disparate, industries right now. For instance, with respirators and other primary supplies, pharma is going to be in a big ripple as we disassociate ourselves with offshore supply developments like supply creation. I think that's going to disrupt us for a long period of time until we rebuild our industry reliance on U.S.-based activities, because this lesson was a massive lesson learned for us as a system. The other part is, yes, I think it's going to start up, but I also am watching some maps and looking at regions hitting peak at various times. We're going to have a 8-week window where peaks are going to be absorbed or felt at different times across the nation. And so we may have little subsets of economic renewal based upon the peak and the rules by which we release the populations.
I think those are all great observations. Let me give you my take as well. I think, to your point, we are going to see an economic expansion, but there are lessons, as Don mentioned, lessons learned. I think individuals that start their own businesses will be very careful to have reserves available for something like this nature to occur again. So whereas some people are living from paycheck to paycheck, I think you're going to see much more cautionary activity that prevents an economic hardship for a family. You know, that whole toilet paper thing is reflective of, do you have supplies if you have to be sequestered and quarantined for a period of time? And I think as a community, we're going to see much more purposeful and intelligent preparation. I also think healthcare is going to take a huge hit. I think there's no way some of these smaller entities and organizations and facilities can maintain the cash flow. So I think you're going to see closures and consolidation. I had a friend, CEO of a hospital in Arkansas, and he had an orthopedic surgeon that they hired as part of their integrated delivery system. So now the orthopedic surgeon works for the healthcare system. And he ran into him in the hallway and he said, "How are you doing?" Orthopedic surgeon said, "I'm doing great, because if this was my business, I would be going under, but it's your business, so you can carry the load." So I think you're going to see more physician groups, ambulatory centers, all consolidated into integrated delivery system. That's my view. So it's been a great conversation, a lot of questions. Thank you for your comments. I'm going to turn over for Dan to give some final thoughts and then some words of advice. I'll give that to Don. Don, you need to be very succinct on this because Don's got a lot of thoughts. I'm going to also ask Dr. Thurgood also to be succinct, but your final word. So first to you, Professor Karnuta, then to Don, and then to Keith.
All right, let me just quickly cover the before I bail out of here. What probably is on everybody's mind, which is the individual provisions. When am I going to get my $1,200 check, right? Well, it's $1,200 for everybody plus $500 per child, but it's limited based on earning level. So as singles, if you're earning $75,000 or more, it's going to start to phase out. And married filing joint, if you make $150,000 or more, it's going to start to phase out. So you might not get anything if you're a big spender. And then unemployment insurance has been expanded as well. People will get more money that are on unemployment, and they'll qualify for longer during this thing. So with all that said, I would say that we just gotta keep our heads, you know, and like I said at the beginning, we're going to make it through this, and we're going to be better for it and stronger for it. And I guess I'll disagree with Dr. Barrett a little bit there in that I think business owners are going to learn from this, and they're going to squirrel away some money for about 6 months. And then they'll forget about it again, and it'll be back to business as usual, because human beings just don't do a good job of learning from their mistakes. So
I will retain my stash of toilet paper. So, Don, Professor Taylor?
Just a couple of points. I believe through this will be the lessons learned in healthcare will be what is really our purpose again. I find it kind of ironic that our intent would be to generate health, and frankly, the best preventive element we as a national health system can provide to be a healthy population. This would be a time I would love to see diminished or a reduction in chronic disease. We may see a refocus of our entire system focused on better health outcomes rather than the business elements. The other is the integration of systems I think are important. We're going to see collaboration financially and collaboration across markets and populations to achieve better results and optimize the way we work together, because we're being forced to now. Particularly other venues, non-hospital, ambulatory surgery, outpatient activities, and ancillary. The last piece I'd like to state is that there's a big gap right now between in the post-acute space, you know, those that you discharge that have been cured, quote unquote, from corona, that are not welcomed in SNFs and post-acute. And so now there has to be this other level of care that those that are beyond home health and need another venue for observation for another few weeks. So there's going to be lots of changes in the system that I think are going to be rather exciting and fun to talk about.
Keith, Dr. Thurgood?
I would say this: keep calm and carry on. There's lots of goodness that's happening right now. We've got more collaboration and insights and information sharing and transparency between the federal government and the state government and even municipalities at the local level. I think that's all great news. We've got neighbors helping neighbors. We can draw a lot of lessons learned from this, but at the end of the day, we need to keep calm, carry on, and know that every individual can make a difference.
That's well said. It sounds like Don's dog wants to make some comments as well, but we'll
Oh, he's muted.
or was that Dan's dog?
No, it's not mine. I think it's.
No, it's my snickerdoodle dog.
Okay, well, I want to thank Dan for being part of this, providing some insight. Dr. Thurgood, Professor Taylor, thank you so much. We're grateful for this podcast and this webinar. Our intent is to expand our knowledge and awareness of all that's going on. To that end, let's put an exclamation point by the comments from Dr. Thurgood. We're in a good place to be, and with tremendous leaders currently in place and preparing the next generation of leaders, we'll weather the storm. So thank you very much. This is Dr. Britt Berrett from the Center for Healthcare Leadership and Management at the Jindal School of Management at the University of Texas at Dallas. We're grateful for your participation today.